You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 19th, 2026. This week, some really nice listener feedback, more long-term data on TAVR versus SAVR, population prevalence of valvular heart disease in the U.S., and a CMS proposal to expand TAVR coverage. First up, let's do some listener feedback on my story of declining VT rates last week. And I have to say that this podcast has very sharp listeners. Dr. Yannick Kirst, or Kirste, I'm sorry about the pronunciation, from Esslingen, Germany, writes to me regarding my coverage of the 15-year declining rate of VT in patients with ICDs in 2 centers in Europe. I was struck by the substantial decline over time of VT therapies, while VF therapy remained low and unchanged. And I liken this to the heart failure trialist paper in the New England Journal of Medicine showing a temporal decline of sudden death in heart failure trials. But Dr. Kirst writes that another potential cause of declining VT intervention in ICD patients may be the gradual change in more permissive programming after the 2012 Made It RIT study, which stunningly showed that permissive programming resulted in both a reduction in shocks, inappropriate shocks, and mortality. Now, if you're not totally familiar with Made It RIT, it's worth a look, as it was one of seminal trials, and it was 10 out of 10 on the BOLD scale. Patients with ICDs were randomized to 3 different strategies of programming: a conventional out-of-the-box type, a high-rate group, and a delayed type. The conventional arm had 2 detection zones for heart rate 170 to 199. There was a 2.5 second delay and a second zone of greater than 200 beats per minute with a second delay before ATP. Patients in the high-rate group received a device programmed to monitor-only zone between 170 and 199 per minute and to a therapy zone beginning at 200 beats per minute after a 2.5 second monitoring therapy. And patients in the delayed therapy group received a device programmed to 3 detection zones, one at 170 to 199 with rhythm detection on and a 60-second delay before initiation of therapy. There was a second tachyarrhythmia detection zone beginning at 200 with rhythm detection on and a 12-second delay before therapy, and a third zone at 250 beats per minute, which was VF or higher with a 2.5 second delay before initiation of therapy. And during an average follow-up of 1.4 years, high-rate therapy and delayed therapy were associated with a 79% and 76% reduction in the first occurrence of inappropriate therapy, respectively. And there were reductions in all-cause mortality of 55% for high-rate versus conventional and 44% reduction for delayed versus conventional. I will tell you that at the time, this was a truly shocking result because few of us thought that being this permissive with VT detection would work. We thought collectively that VT was terrible for patients and the earlier we intervened was better, and Made It RIT completely exploded that convention or therapeutic fashion. And I think the trial taught us that A, groupthink should always be tested in RCTs, and B, a lot of VT goes away on its own, and C, high rates are often non-VT rhythms like AFib or sinus tachycardia. So Dr. Yannick Kirst is correct. Some of the decline in VT noted in the Basel-led study may have been due to permissive programming. And good on him for bringing this up, as it is always good to revisit seminal trials, and boy, was Made It RIT worth a relook. It's New England Journal of Medicine, 2012. All right, now the vast majority of this podcast is going to be on the long-term data on TAVR versus SAVR that just came out in JACC. So the conundrum faced by patients with severe isolated AS without a bicuspid valve continues with this newest long-term data, and JACC has published 10-year data on the intermediate risk PARTNER 2 trial. That's balloon expandable trial, as well as an observational comparison between the newest balloon expandable valve called SAPIEN 3 versus the balloon expandable valve that was used in the trial PARTNER 2, which is no longer used, called the SAPIEN XT. And this is complicated stuff. Let me first tell you the results, then rehash the recent 6 to 7 year data on the self-expander valve that was published this winter, and then some comments on the totality of the evidence and the difficulty of the decision. But before any details, let's set out that there is a tension between having long-term data and having new iterations of devices. A trial starts out with a valve or stent or pacing device or whatever that's available at that time. The trial takes a couple years. During or after the trial, the biomechanical engineers are not sitting on their butts doing nothing. They're iterating, and new iterations of the valve or stent or device come out. And that iteration is probably or clearly better in some way. And then how do we translate evidence generated from old devices to the new devices? And I'm asking, I don't know. So now to the data. PARTNER 2 randomized 1,900 patients with severe AS and intermediate risk between 2011 and 2013, and the trial was planned for 5 years. So to obtain 10-year data, patients had to reconsent at 5 years, and the authors did something called a vital status sweep, and this was implemented to improve data completeness for all-cause mortality. So it was about 1,000 patients per group. 3/4 received transfemoral TAVR, and 24% had transapical. The mean age of patients was old at 82 years, and almost half were women. The STS surgical risk was about 5.8%, and the results at 10 years, they had some data on about 90% of both groups. All-cause 10-year mortality with the vital status sweeps was 86.1% TAVR, 82.8% after surgery. That 3.3% increase in absolute terms had a hazard ratio of 1.13, which was statistically significant. When stratified by access route, however, rates of all-cause mortality for TAVR and surgery in the transfemoral group were similar, 83.9 versus 82.1. That's not significant, whereas mortality was higher with TAVR in the transapical group, 93.2 versus 85.1. And the P for interaction in that subgroup was positive. The key finding, I think, though, was this. Cumulative incident rates of aortic valve re-intervention at 10 years were 6.3% for TAVR and 1.6% for surgery, and that's highly significant. Now, my comments. When you look at the overall data, TAVI looks worse. Higher mortality and about 4x higher rate of valve interventions. However, there are two big caveats, and I mean big ones. One is that most of the harm in the trial came in a transapical route. And when you look at transfemoral mortality, it's still higher, but it's so close as to not be significant. Now, the problem with hanging the excess mortality on the transapical route is not only that it is an underpowered subgroup susceptible to noise, but the transapical route requires a decision, and many things go into that decision. So these patients could be different. Say there's more atherosclerosis, and these differences may drive the outcomes rather than just the valve and surgical approach. But the biggest caveat, I think, is that PARTNER 2 used the SAPIEN XT valve, which has been replaced now with the SAPIEN 3 valve. Now, I don't have enough content expertise to explain the exact differences, but suffice to say, implanters obviously thought it's better because SAPIEN XT is no longer taken off the shelf, and these valves are done with SAPIEN 3. Now, another paper in JACC, which I've linked to, is a reasonable effort to assess SAPIEN 3 performance, the new valve. A large group of authors, some from PARTNER 2, took about 900 patients who had the new SAPIEN 3 valve for severe AS and intermediate risk in the Partner 2 SAPIEN 3 Intermediate Risk Registry and compared them to a matched group in the actual trial who had surgical aortic valve replacement. So they used propensity matching to approximate baseline characteristics in these two non-randomized groups, one from the registry, the other from the trial. So this is a observational comparison study. The registry, like the trial, was designed as 5-year studies, so again, they had to reconsent patients and then use vital status sweeps to get mortality data. Notably, and I'll just cite the paper here, quote, the trial sponsor, Edwards Life Sciences, owned and maintained study data, performed statistical analysis in collaboration with the authors, and provided editorial support under the direction of the authors, end quote, no comment, just I read that. Results. After propensity score matching, there were 783 patients in each group, and in the matched cohort, 367 TAVR and 378 surgical patients completed the 5-year follow-up, and of these, 40% and 59% respectively did not reconsent for extended follow-up. So at 10-year follow-up, there were 59 TAVR and 54 surgical patients who were alive and on study, and 409 TAVR and 336 surgical patients who died, resulting in 60% of the TAVR group and 54% of the surgical patients with a known vital status for all-cause mortality analysis. Implementation of the vital status sweep improved the completeness of mortality data to 88% and 90% for the TAVR and surgery groups at 10 years. So, in sum, at 10 years, all-cause mortality with this vital status sweep was 83.4% for TAVR and 82.3% for surgery, and that hazard ratio is 1.01 and obviously not statistically different. Interesting was that death with the vital status sweep was similar between TAVR and surgery for the transfemoral and transapical routes in this non-randomized comparison. Reintervention in this study was also lower and no different, 2.0 versus 1.9% in the TAVR versus SAVR arm. Echo data at 10 years was available in only 60 patients, and it was valve function seems similar in terms of gradient and effective orifice area, though aortic insufficiency was 2 times more in the TAVR arm. And I wouldn't make much of the echo data since it's only available in 60 patients. The authors were very fair about the limitations of this analysis, which were numerous, right? It's non-randomized, and of course there could be unmeasured confounders. It, of course, only uses balloon expandable valves. Reconsenting resulted in asymmetrically and potentially non-random loss of follow-up, which was greater in the surgical patients. And the vital status sweep, which is better than nothing, cannot address missingness of data for other endpoints. And there was no central adjudication of clinical events after 5 years. But on the other hand, the registry was started within a year of the completion of the trial. The patients were similar in characteristics, and taking a Bayesian view, you'd expect a new valve to be better in many ways, including the fact that in the registry, and now it is normal to use CTA to guide valve choice, which was not typical in the main trial. Now, Doctors David Capodanno and Camille Bujak have an excellent accompanying editorial. They have a figure. Figure 1 is a table of 5 studies that have gone on for more than 6 to 7 years. Other than these 2 that I just mentioned, let me just mention the other 3. Notion, which is an RCT in Denmark. Small numbers of patients, 280, randomized 1-to-1, with either a self-expanding core valve or SAVR. These patients were 79 years old, but had a lower STS score of 3% versus 5.3% in Partner 2. And the main results of Notion was that after 10 years, the risk of the composite outcome, of all-cause mortality, stroke, or MI, was 65.5% in both arms, so obviously no difference. Now there's the Partner 3 trial of low surgical risk patients, has reported outcomes at 7 years. Last October in the New England Journal of Medicine, there were slightly more than 900 patients randomized. Recall that Partner 3 was the first TAVR trial to mysteriously add rehospitalization in the primary endpoint, as all the other trials had stroke and death. At 7 years, the incidence of the primary outcome of death, stroke, or rehospitalization was 34.6% TAVR, 37.2% surgery, which was not significantly different. However, for death, it was higher with TAVR, 19.5 versus 16.8%, though not statistically significant. Stroke was about the same. Reinterventions was about the same, and slightly more than half of the interventions were surgical explants. The fifth trial that was mentioned in the editorial that has reported long-term results is the Evolute Low Risk, and here there's 6 to 7 year results. This is the self-expanding valve. There were about 1,500 patients. Death again was higher in the TAVR arm, but not significant. It was 23.3 versus 20.2. Reintervention, though, was statistically higher in the TAVR arm, 9.8 versus 6%. And most reinterventions in Evolute Low Risk were surgical explants. The editorialists note different patterns of valve failure after 5 years. In Evolute Low Risk, aortic regurg predominated, whereas in Partner 2A, stenosis was slightly more common, especially beyond 5 years. And of course, these patterns mirror observations in surgical valves, with restenosis more typical of bovine pericardial valves and regurgitation more frequent in porcine valves. The modes of intervention were also different. In Partner 2A, nearly all patients who had reintervention had TAVR in TAVR, whereas surgical reintervention predominated in the Evolute Low Risk group, and that likely reflects differences in patient age, the risk of coronary occlusion relative to prosthesis type, and mechanism of failure. The last paragraph of their editorial is good, and I'll just cite it. Quote, the 10-year Partner 2A results and the accompanying observational analysis, despite the challenges of long-term follow-up, represent an important contribution to the evidence informing the lifetime management of aortic stenosis, and at the same time make the forthcoming longer-term outcomes of Partner 3 and Evolute Low Risk even more awaited. They do not diminish the transformative impact of TAVR, but serve as a timely reminder that durability remains a central consideration as the field enters its second decade, end quote. Let me add one more commentary that was published. Victor Dayan, Sanjay Kaul, and Benoit Shaw have written an editorial in European Heart Journal this past week. It's entitled TAVR versus SAVR, Age versus Lifetime Perspective. And they push back strongly on the recent ESC guidelines, which have lowered the default age threshold for TAVI from age 75 to 70. This is now a Class 1 level of evidence A, the strongest type, so obviously the guideline writers have confidence in TAVI as first-line therapy for younger, lower-risk patients. Now, the argument of the editorialists, Dayan, Kaul, and Shaw, which is well argued, I'd say, make the case that for SAVR is the best first-line choice. First, they cite 5 lines of evidence. 1, Partner 3 at 7 years, death or disabling stroke was 31% higher in the TAVR arm. 2, in Evolute Low Risk, non-inferiority may have been met, but a non-significantly higher rate in death or disabling stroke favored SAVR. This was observed, and the reintervention rate was 68% higher in the TAVR arm. Evidence 3, in the Notion 2 trial, which included younger patients at low risk, mean age 71, this trial failed to establish non-inferiority of TAVI relative to SAVR for death, stroke, or rehospitalization. Evidence 4, UK TAVI trial, which enrolled older patients, mean age 81, at low to intermediate risk, reported that TAVI was non-inferior to surgery regarding all-cause mortality at 1 year. However, unpublished 5-year follow-up uncovered a 78% higher risk of stroke with TAVI. And Evidence 5, a Bayesian hierarchical meta-analysis studies with at least 5-year follow-up showed TAVI was associated with a higher risk of death and stroke in low to intermediate risk patients. And so robust RCT data for low-risk patients only extend to 7 years, but 70 years old has a much greater life expectancy, and using life tables up to 15 years. So the editorialists argue there's not enough data. While some of the data, they say, is reassuring, there are signs, too, of a catch-up where death and disabling stroke and reintervention seem to be going the wrong way with TAVI. And so they make the argument that SAVR first for young people with greater than 10 years life expectancy, and they give 4 big reasons. 1 is it preserves coronary access. 2, SAVR optimizes hemodynamics for future interventions. For instance, surgical aortic valve allows for annular or root enlargement, enabling the placement of larger prostheses, which then decreases the risk of prosthesis patient mismatch and higher gradients during future TAVI in SAVR interventions. Third reason, there's flexibility in reinterventions. Patients starting with TAVI may be limited to TAVI and TAVI. And if unfeasible, TAVI explant becomes necessary, and that's a procedure with very high operative mortality, up to 17% in some studies. But even TAVI and TAVI is not nothing, as the authors cite a SAPIEN 3 registry with a 1-year mortality of approximately 20%. And the 4th reason why they would choose SAVR first is procedure-related complications. While atrial fibrillation or bleeding after surgery are transient complications, higher pacemaker rates and paravalvular AI from TAVR are often persistent and have cumulatively negative effects. Okay, so my final comments are that first, it's exemplary that we have this 10-year data and that we're having this discussion. We don't have this kind of data with many other cardiac interventions. While vital status sweeps are not the same as staying in a trial, it's pretty good. And as I have said, for the older patient who has high surgical risk, TAVR is amazing. It's been a great invention. The question is younger people who will likely outlive their first valve replacement. Now, the main tension for us here on this evidence-based medicine podcast is the tension between long-term evidence and iteration. Now, Partner 2 trial looks worse for TAVR, but it was with a SAPIEN XT valve. Now we implant SAPIEN 3, and it's a better valve. So does the trial data apply to the new valve? I don't think it does. David Cohn wrote to me on X that his favorite aphorism for this issue is, quote, "You can either have long-term outcomes data or new technology, but not both." To me, though, altogether, SAVR does look slightly better over the long term, though it's close. Doctors Diane Call and Shaw make a compelling case for SAVR first in young patients, but honestly, patients at age 70 face a tough decision. TAVR is clearly going to be easier on them. Yes, it may not last as long, but patients may say, who knows what happens to me? I could die of cancer in 5 years, and then I've avoided 6 months of that 5 years during having a hard recovery from surgery. And I think patients feel differently. I feel differently. I'm having dental surgery this afternoon, and I've chosen to do an easier procedure knowing that 2 to 5 to 10 years down the road, I may need to do another surgery. But I may not be here then. So I'm going with the easier surgery now rather than the more complete surgery. And some patients with aortic stenosis may want SAVR, knowing that longer term there would be better results and surely more options for reinterventions. Specifically, they may want to avoid a TAVI explant, which is terrible. But TAVI now is an understandable choice. I also suspect that anatomy matters too. Now everybody gets a CTA. Maybe the presence of ideal anatomy for TAVI and the odds for a great result are high. Now trials give us average effects, but with modern imaging and modern valve techniques and an utterly biased multidisciplinary team, may recommend the TAVI over SAVR in a young person based on anatomy. The problem, though, is that I'm not sure there are many unbiased multidisciplinary teams in the U.S. I'm not even sure we have MDT teams in the U.S. I could be wrong, but what I saw in the U.K. and in Denmark were doctors that make the same amount of money regardless of the number of procedures they do. And to me, that reduces the risk of overuse of TAVR. In our system in the U.S., and perhaps in Germany as well, there may be outside pressures to do TAVI when SAVR would be better. Plus, we know that cardiologists control the patients, so of course there is that bias. Now, we will know more when the low-risk trials get out here to 10 years, but I predict a clear best choice in all patients is going to remain uncertain and largely dependent on getting wise advice from an unbiased multidisciplinary team and strongly going to be preference-sensitive decisions from a patient point of view. All right, next topic is the PREVUE-VALVE Study. Now, did you ever wonder what the prevalence of valvular heart disease was in the population? Well, a group led by Dr. David Cohn at Columbia University did, and their study was unique and novel and worth a mention. The authors chose a random sample of 65 to 85-year-olds who had filled a prescription at CVS or Walgreens, and they invited them to participate in the study via email or text or direct mail. The sampling strategy was based on zip code and demographics and was used to identify potential candidates from among the pool of eligible CVS and Walgreens pharmacy customers. Now, individuals who were interested in participating were referred to an online portal, and then they had to go through and complete an electronic screening that verified their eligibility and solicited basic demographic data. Then, an independent research organization contacted eligible individuals to obtain informed consent and schedule the study procedure. Patients were compensated with a $25 gift card after they completed the in-home study procedures. But get this, all study procedures to detect the valvular heart disease were performed during a single study at the participant's home, where they had a comprehensive 2D transthoracic echo by a certified cardiac sonographer. The primary endpoint of the study was the prevalence of moderate or greater valvular heart disease, which was defined by more than moderate heart disease of any valve. And so they sent invitations to more than 650,000 individuals and offered the opportunity to participate in this study. Of these, about 8,200 or 1.3% visited the study portal. Ultimately, 3,300 completed the informed consent process and agreed to enroll, and 3,000 of them had completed the study procedures. 3,000 patients had in-home echo. That's pretty wild. And the sample included individuals from all 50 states and was racially and ethnically diverse. The median age was 71 years, and 57% were female. Overall prevalence of valvular heart disease, guess what it was? 8.2%. And of course, it had an age gradient, right? So 5.1% for 65 to 69-year-olds, and then gradually getting more up to nearly 15% for 80 to 85-year-olds. The weighted prevalence of greater than moderate valvular heart disease by valve type was 0.7% for aortic insufficiency, 3.1% aortic stenosis, 2.0% MR, and 3.7% TR. And so the authors applied this prevalence data to the population of the U.S. and estimated that 4.7 million U.S. adults have more than moderate valvular heart disease. Also notable, and I actually didn't know this, was a lower incidence of valvular heart disease among black individuals, especially AI and AS, which, of course, helps explain why some studies show that black patients are less likely to have TAVR or SAVR. So my comments, this is a neat study, right? It avoids the bias of studying patients who come to a clinic. Now, at first, I thought that it might be a biased assessment because patients who agree to have an echo and fill out all this paperwork might have worrisome symptoms, and thus these estimates might be an overestimate. But Dr. Cohn messaged me that they doesn't think that's the case because their KCCQ was off the chart for good numbers. So these were happy, healthy patients. I still wonder, though, about sampling. Now, another lesson, of course, from this is that accurate population-level prevalence estimates can actually be obtained pretty easily with these new age tools like databases and modern telecommunications with text messages and stuff. And I think that's pretty nifty. Recall that the DanCavas screening trial in Denmark enrolled with invitations via national email. That said, I do worry that studies such as these could create disease recognition campaigns which are a modern-day scourge. I despise disease creation because ultimately it is to drive profits. Now, the authors don't do this. It's not them. So I don't want to implicate them. It's just that I can see a company that makes valve intervention tools creating advertisements describing the high prevalence of TR or MR in the community. If this would happen, our profession should resist it strongly. But finally, none of this should be necessary, right? Because if patients come in for health checks, and patients have health checks, I mean, everybody has a health check. You might go to an urgent care center for an ear infection, for instance. A clinician who does a basic exam should be able to hear moderate to severe valvular heart disease. You would think that if someone had moderate to severe MR and they had a clinician listen to their heart, it would be detected. But sadly, I'm sorry to say that A, fewer patients even get their heart examined, and B, those that do could easily have their moderate to severe AI or MR missed. But I just want to say, still, to this day, in 2026, I still listen to the heart of every patient I see, and I actually do listen for stuff. So I still recommend that when you listen to the heart, that you actually listen in a quiet room and just listen for valvular heart disease. Sometimes you'll pick it up. All right, next topic is that CMS in the U.S. has proposed new coverage for TAVR. This proposed decision memo was released and is open for comment until July 15th. And the big changes are that it will expand coverage for TAVR to asymptomatic severe AS, of course, with coverage with evidence development, and I'll talk about that. And it will also allow for TAVR to be done with one TAVR operator. It also revises coverage criteria for pre-procedural patient assessment and comments on hospital procedure volume requirements. Now, the coverage with evidence, I like. This is a good thing. And it includes 17 requirements for the studies to be conducted, which makes it look like they're being really strict about what kind of studies can be done. But sadly, not one of these 17 requirements is that they do an RCT, which is, of course, the best way to study things. The American Association of Thoracic Surgeons are opposed to this new coverage, and so am I. The AATS writes to its members that, quote, "We believe the current framework represents a deeply problematic outcome that eliminates mandatory in-person surgeon evaluation of patients undergoing consideration of TAVR or intraprocedural surgical expertise. This potentially puts patients at risk." The AATS maintains that the following positions, which were not included in the proposed framework, are of the utmost importance for patient safety. 1. Dual specialty operator standards. The proposed framework eliminates joint operator requirement, and we ask that the coverage decision should explicitly note that dual specialty operators consisting of both a cardiac surgeon and an interventional cardiologist are optimal for patient care. Number 2, requirements for new programs. The AATS asks for the first year of operation, any new TAVR site must be required to utilize a dual specialty operator composition consisting of both a cardiac surgeon and an interventional cardiologist. And the third position is a coverage with evidence development. We ask that TAVR be covered under coverage with evidence development for the following indications or conditions, and there's multiple ones that they want at coverage with evidence, and that is asymptomatic AS, bicuspid anatomy, moderate aortic stenosis, valve-in-valve TAVR, aortic insufficiency, and low-risk aortic stenosis patients. They also want coverage with evidence for new TAVR programs for hospitals without TAVR experience, and they would like coverage with evidence for newly FDA-approved TAVR valves. And finally, they write, we ask that for the above CED indications and conditions, the heart team and hospital must participate in a prospective national audited registry that consistently enrolls TAVR patients, follows them for at least 1 year, and reports on the relevant clinical outcomes. But I actually would go farther than this. I think this is great. It's obviously what we should do because this is new. It has extreme bearing on low-risk patients. And we have a chance to mandate collection of data, and we should do it. But I would even go farther, and I would add that the evidence base for allowing aortic valve replacement with TAVR in asymptomatic AS is terrible. It's terrible. I was asked this winter by the British Cardiac Interventional Society to present there on the 3 worst trials in interventional cardiology that affect practice still, and I chose early TAVR to lead the list. Now, early TAVR, which is the underpinning RCT, this was an RCT comparing early TAVR to clinical surveillance in patients with severe asymptomatic AS. And of course, that trial included an endpoint of death, stroke, and rehospitalization for cardiac causes, which sounds kind of normal on the surface if you just let it buzz over you. And death and stroke in a trial were similar, but the entire positive endpoint was driven by rehospitalization, the majority of which was for conversion to TAVR, which is ridiculous because just months before, these patients passed a stress test to show that they were asymptomatic. This was subtraction anxiety run amok, meaning patients had severe AS, one group got fixed and the other group didn't get fixed, and the group that didn't get fixed just said, okay, I want to get fixed. So it was a trial designed by industry to be positive and sell more valves, which it is likely to do based on this new CMS proposal. So I'm against it. I'm against even having it as a indication, asymptomatic AS. So that's it for this week in cardiology. I know I went a little long this week because of all this data on TAVR and SAVR. And so if you have comments, please let me know. And remember, if you like this podcast, take the time, give us a rating, write us a review. And if you don't agree with something I say, write me a note and we'll do some more listener feedback. And I'm really learning a lot from listener feedback. So thank you very much. And until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.